kind words. Although, I don't think I deserve all of this. This is more like the matrimonial ad that, people give for their kids. There are a lot of lies said. But anyway, at the outset, I'd like to thank Dr. Neeraj Jain and Dr. Rajan for inviting me back to my home organization. And it is always a pleasure speaking in this organization. I would also like to begin with a caveat that covering all 3 cell lines in 30 minutes is not possible. So I will just cover as many salient features as I can. So the topic that I have been given is called ABC of CBC, although it is more like XYZ of CBC because ABC we all know. This is a pathologist gathering. So to begin, let me just check how many of you are awake. Can you identify this person? Anybody? Yeah, he is Sir Wallace Coulter. I was just checking how many are awake in the auditorium. So he won the Nobel Prize for detecting the Coulter principle, and you can call him the father of the modern hematology analyzer. Whatever we know today is thanks to this gentleman. So in most modern hematology analyzers today, the basic principle that we use is called fluorescent flow cytometry. Basically, there is a laser beam of light. There is a forward scatter, which is indicator of the cell volume or the cell size. There is a side scatter, which tells about the internal cell structure or the granularity of the cells. And there is a side fluorescence, which is telling about the RNA, DNA information of the cell. So the more the RNA, DNA, the more immature the cell line is. So broadly, based on this, different analyzers have different technology. The one that I use is called Mindray BC6800 Plus, which uses the SF Cube technology. So what it does is, there are 3 axes. On the x-axis is the side scatter or the granularity. On the y-axis is the fluorescence. And on the z-axis is the forward scatter or the cell size. So based on these scatter plot, we can differentiate a lot of cell lines. And some of them are new cell lines which have led to all these novel parameters. So this cell line you see here, the green area, this is the area of the lymphocyte. Just above is this pink area is the area of the monocyte, which is of course bigger in size. This area in the middle is the neutrophil, which has got more side scatter than both lympho and mono. This area here is the eosinophil, which has got the maximum side scatter. The basophil is along with the neutrophil only, it can be juxtaposed on another scattergram. Now this is the interesting area here. This area is the HSC or the high fluorescence cells. Now this is nothing but what we used to call earlier as the Downey cells or the Turk cells, virocytes, transformed lymphocytes, whatever you want to call it. Now we've identified this as an area HFC, high fluorescence cell, and we can derive a biological reference interval for it. So this has got a lot of prognostic significance in dengue and some other conditions I will discuss later, but this is an important cell line. This area here is the area of the immature granulocytes, which is nothing but your promyelocytes, myelocytes and metamyelocytes put together. Now again we can put a biological reference interval to it, and we can look for shift to left in a more numerical format. This area here to the left of the neutrophil is the area of the nucleated RBCs, and basically it can also be differentiated from basophil, neutrophil and NRBCs on a WNB scattergram. This is the band form, which is not part of the immature granulocyte, just above the neutrophil. And this area to the left of the nucleated RBC is the area of platelet counts. This is another area which is between the neutrophil and the eosinophil. This is called infected RBC flag on my analyzer. Basically, this is nothing but it is telling you about the malarial parasite. Different analyzers will use different algorithms. But now most modern analyzers will give you a flag for the malarial parasites, and you can detect a lot more malarial parasites even when the clinician has not asked for it and you are not looking for it. So it is very important to look at these, scatter plots. It is very important to look at all the flags that are coming out of the modern analyzer, and not only train yourself but train your technician, because at the end of the day he is the guy who is going to flag those alarms to you. So just another technology that I want to bring. Same way, when we do the neutrophil or any other cell line along the XYZ axis, we can differentiate all cell lines into X, Y and Z components. So again, like any other cell line, Neu-X depicts complexity, Neu-Y the DNA RNA content, and Neu-Z the cell size. Now why I am telling this is because Neu-Y is an important parameter which can help diagnose sepsis and differentiate bacteremia from septicemia, which I will discuss later. So with this backdrop, I will discuss the novel parameters that I am going to broadly discuss in the presentation. In the RBC cell line, we are going to discuss automated nucleated RBCs and auto correction for TLCs. We are going to discuss immature reticulocyte fractions. This third parameter is my most favorite, red hemoglobin, which has got tons and tons of utility, especially in a nutritional anemia country. Then we will discuss optical RBCs, and last but not the least, the Malaria Flag. In the WBC cell line, we are going to discuss immature granulocytes, MLR or the neutrophil lymphocyte ratio. This is a parameter that has been very widely used now in both sepsis, as well as we used it very efficiently in COVID as well. Then Neu-Y, which is probably the most sensitive marker for the differentiation of bacteremia and septicemia, and high fluorescent cells, which are nothing but your downy cells or virocytes, whatever you want to call them. In the platelets, we will discuss optical stroke fluorescent platelets vis-a-vis impedance platelets, and this parameter called immature platelet fraction that was very useful for us in managing a lot of dengue patients, prognosing, as well as doing siphoning of patients who would require admission or not. So coming to the first cell line, the RBC cell line, this is the poorest cell lines amongst all three cell lines, because most of the limelight is hogged in most presentations by WBC and platelet talks. RBC is a poor cousin, doesn't attract that much attention because it is neither very useful in leukemia nor in dengue, so it's kind of in the side. But now because of red hemoglobin, it has started to gain a lot of traction back again. So first, coming to nucleated RBC, we all know that when there is severe demand for RBCs or when there is stressed erythropoiesis, there is increased nucleated RBCs into the bloodstream. Now most modern analyzers can do these automated nucleated RBC counts along with your normal differentials, and can also auto correct the TLC which is falsely elevated in the presence of the nucleated RBCs. So this is one of my cases. So as you can see in the WBC flag, there is this AND symbol. So whenever the analyzer flags an AND symbol, it indicates that the WBC results have been corrected due to the interference of the nucleated RBCs. And as you can look at the bottom, the nucleated RBCs are 46 per 100 WBCs. So whenever there are increased nucleated RBCs, it counts the nucleated RBC as well as auto corrects the WBC. So this is the histograms and the scatter plots from the same patients. As you can see, there is a lot of increased red cell distribution width. The base of the RBC histogram is white. And coming to this WNB channel, where there is a forward scatter and there is a fluorescence. This blue area is the area of the neutrophils, and this pink area here is the area of the nucleated RBCs. So it is just to the left of neutrophil and the right of lymphocyte on the scatter plot. So this is the WNB scattergram, which is the same scatter plot enlarged. So this is neutrophil, just to the left is the basophil, and further left is the area of the nucleated RBCs. So we should start developing the habit of looking at our histograms and scatter plots more efficiently. Next we have the reticulocytes, and we know that reticulocytes do not have a cell nucleus. They just have remaining net-like ribosomal RNA, which can be detected during fluorescence. So these are the 4 stages of reticulocyte maturation. As you move from stage 1 to stage 4, you can see that the RNA content is decreasing. So likewise, the fluorescence is also decreasing from stage 1 to stage 4. So this stage 1 and stage 2 together is called as the area of the HFR or the high fluorescence reticulocyte. Stage 3 is the medium fluorescence reticulocyte, and stage 4, the most mature reticulocyte, is called the least fluorescence reticulocyte. So when you combine HFR and MFR together, there is something called as the immature reticulocyte fraction. Now why is it important? In a normal macrocytic stroke megaloblastic anemia, the IRF is high even when the retic is normal. So untreated megaloblastic anemia will have high IRF. Whereas other causes of macrocytosis which are not nutritionally linked will not have a high IRF, they have a normal immature reticulocyte fraction. So high IRF can help differentiate nutritional from non-nutritional causes of macro and even microcytic anemia. Next, coming to ret hemoglobin, this is the most emergent parameter in anemia diagnosis. It's has loads of utility. When you combine it with the serum iron profile, it is a very good tool to determine whether iron is due to low iron stores in the body or there is an inability of the reticulocyte to hemoglobinize itself. So primarily it has 3 roles. A, it can be used for the diagnosis of iron deficiency anemia in adults and children. B, it is an early measure of response to iron therapy. Within 72 hours, it is the first parameter to elevate much before ferritin, much before hemoglobin. And it is also an early indicator of iron restricted erythropoiesis in patients of anemia of chronic renal failure who are receiving erythropoietin therapy. So it can assess functional iron availability for erythropoiesis over the past 2 to 3 days. It is recommended by European best practice guidelines in management of anemia of patients of CRF. And there is no other manual method to diagnose ret hemoglobin. It can only be diagnosed through an analyzer. Now this is the famous Thomas diagram. For those of you who have kids who are still giving NEET, this diagram almost comes every second year as an MCQ in NEET paper. So on the y-axis is the ret hemoglobin and on the x-axis is the ferritin index, which is nothing but transferrin receptor on log ferritin. So higher the ferritin index, the more iron deficient the patient is. So first coming to this right column here, low ret hemoglobin, high ferritin index, classical iron deficiency, give iron straight. Normal ret hemoglobin content, high ferritin index, latent iron deficiency, again give iron. This is where the use begins. Anemia of chronic disease with full iron stores are there. Ret hemoglobin content is normal. Ferritin index is low. You just give erythropoietin, you don't give iron. And when ret hemoglobin and ferritin index both are low, this is ACD with full iron stores, functional iron deficiency. You give both erythropoietin as well as IV iron. So this is basically the Thomas diagram, which basically also paves the path for what management especially to do for an anemia of chronic renal failure. This is the biological reference interval we established in our lab for 1473 selected normal patients. The mean value was 31.6 and a standard deviation was 2.4. There was not much difference between male and female. However, there is a caveat. You must establish your own biological reference interval because different analyzers are using different fluorescent dyes, different algorithms. So just don't juxtapose our normal reference and do it on your analyzer. So this is one of my cases. This is a case of iron deficiency anemia before treatment. Hemoglobin is 9.4 and you can see that hemoglobin is low. Our normal range begins from 27, 28. This is 23.5. And this is the same patient 3 days after intravenous colloidal iron. Hemoglobin is only 9.4 to 9.5. But look at the jump of ret hemoglobin. From 23 it has jumped to 30.8. So whether your iron therapy is working or not, this is the earliest marker to look for response to treatment also. Coming next to optical RBCs. So whenever in an analyzer the RBCs are isovolumetrically spherized as we do for retic count, the my theory of light scatters for homogeneous spheres comes into play. The low angle scatter determines the volume and the high angle scatter determines the hemoglobin concentration. So once you fix the RBCs, you can do this test only after fixing it. So if you don't have reticulocyte in your analyzer, then this test is not possible. So on the y-axis is the volume and on the x-axis is the hemoglobin concentration. This area to the left is the area of hypochromia. To the right is the area of hyperchromia. This area below is microcytosis, top is macrocytosis, and this square in the center, this is the square of normocytic normochromic. So it's just a visual interface, no data, no numbers. Just look at the scatter plot and you can broadly diagnose your case. So this is my case 1. You can see most of the scatter is in the normocytic normochromic area. There is some tailing that happens in the macrocytosis in the analyzer. This has to be ignored. And this pink area is the area of the reticulocyte. So you can also know your relative reticulocyte percent. So this is normocytic normochromic case. You can look at the indices, they are normal. Case 2, there is both microcytosis as well as hypochromia in this case. Look at this scatter plot carefully. This is a scatter plot of iron deficiency in anemia. We can differentiate beta thal scatter plot from IDA just by the visual interface. So if you look, hemoglobin is 9.4, MCD is 69, RDW is 21.5, classical case of iron deficiency anemia. Just look at this scatter plot. There is only microcytosis, there is no hypochromia in this case. So unlike the previous case where there was both microcytosis and hypochromia, there is only microcytosis here. This is a case of beta thal trait. You can see the Mainzer index, MCV by RBC is less than 10. The chromatogram also showed A2 percentage, 5.7%. So it is a classical beta thal trait. Now look at this case. This is got both microcytosis as well as hypochromia. This is the wrong case. This is a case of both beta thal and IDA. So when you have both beta thal and IDA, you will not be able to differentiate IDA from the time. But when you have single cases, you will be able to differentiate. Now this is a case of dimorphic anemia. There is bimodal peak. You can look at the indices, it is going from below to top everywhere. So just a visual interface and you get to know even before you look at the numbers. So just to conclude, RBC related graphical representation is the key for pattern recognition, and we can detect clinical decision making much faster. And even unsuspected conditions may be diagnosed. Sometimes we have picked up hereditary spherocytosis. You can look at the scatter plot going toward hyperchromasia and you can, get the hint there. But there is a need for greater awareness, first amongst pathologists and next among their technologists as well. Next, coming to malarial flag. So in a busy laboratory, it has the potential to identify unsuspected cases of malaria. Just 3 days back, I had a patient suspected of dengue. They have sent for CBC, NS1, PCR, dengue antibody, everything negative. Platelet count was just 36. And just the infected RBC flag made me look for the malarial parasite longer. That even the parasite density was low. That same patient had come to 3 previous laboratories to me in the last 2-3 days. None of them had picked up the malarial parasite. I would have also missed it if I had not looked at the flag. So this flagging can help you detect a lot more malaria than you would otherwise detect. And the sensitivity and specificity of flag in various studies is 93 and 97, but this is for Vivax. For falciparum it is a little lower. So as you can see on the scatter plot, this area between neutrophil and eosinophil, this is abutting the infected RBCs. But when I tilt the cube on the side, this area gets differentiated. So it is roughly in between the neutrophil and the eosinophil on the scatter plot. But when you move the cube, then the juxtaposed area gets, even the machine is showing this red flag of infected RBCs. So whenever your machine is giving you a malarial flag, you must train the technologist to alarm it off to you. Next, coming to the WBC parameters. Now, immature granulocytes is something that the machines are giving numerically. This includes your promyelo, myelo and metamyelocytes. The biological reference interval that we established in our lab is 0 to 0.7. Again, it can vary from lab to lab. You have to determine your own reference intervals. It is a good prognostic marker for diagnosing bacterial infection and sepsis. But unfortunately, it does not differentiate that much between bacteremia and septicemia. So there is no cutoff where, IMG will move from bacteremia to septicemia. For that, we have other markers. This is the paper we presented at ISLH Melbourne. That was the COVID year where we had to do online presentation. So I just briefly tell the objective. The study was to evaluate novel parameters like Neu-Y, monoZ, neutrophil lymphocyte ratio, immature granulocytes, and to differentiate bacteremia from septicemia. So these are the results. We had a Uden index that was calculated, and the cutoff for the 2 most promising parameters were for Neu-Y, it was 492. So if the Neu-Y is more than 492, it is a most sensitive marker for the differentiation of bacteremia from septicemia. And this is the other marker, neutrophil lymphocyte ratio, which unfortunately doesn't require any fluorescence. Even the basic analyzer can do it. This was the most specific marker. Like Neu-Y was the most sensitive marker. This was the most specific marker to differentiate bacteremia from septicemia. And the cutoff was 10.66. So broadly, at a cutoff of NLR more than 10 would be probably the most specific marker for the differentiation of bacteremia from septicemia. So this is the diagnostic sensitivity. For Neu-Y, the diagnostic sensitivity was 100%, specificity was 93.3%, and for NLR the sensitivity was 86%, but the specificity was 100%. Now this NLR has also been seen, so our conclusion was Neu-Y and NLR were the most promising markers to differentiate bacteremia from septicemia. However, they are not reliable markers to predict severity of sepsis compared to procalcitonin. That was the second part of our study, not relevant here. So we tried to compare NLR with the three inflammatory markers CRP, ferritin and interleukin 6 and differentiated into two groups between mild and moderate severe groups. So one was CRP less than 20, other was CRP more than 20. And the mean values for CRP less than 20 was 3.77, for more than 20 was 7.25. Similarly for ferritin it was 4 and 6.7, and for IL-6 again it was 4 and 6.1. So roughly at a cutoff of 4 NLR, you can differentiate mild from moderate to severe COVID infections. So NLR is also an important marker in the prognostication of COVID infections, but the principle is totally different. In sepsis, it is happening because of neutrophilic leukocytosis and shift to left. Whereas in COVID, it is happening due to relative neutrophilia, primarily due to lymphopenia. So the mechanism is different, and hence they have different cutoffs also. So next marker is high fluorescent cells. As I told, this is nothing but your virocytes, transformed lymphocytes, Downy cells. This is basically increased in all viral infections, but especially the amount to which they are increased in dengue is not so much as in other non-dengue viral infections. So broadly from our studies we have seen that it usually begins to rise from day 4 of the dengue infection, and it has got prognostic significance in platelet recovery. So my normal range for HFC that we established in our lab was 0 to 0.4%. This is day 4, I am not beginning from day 1 for the patient. The HFC is increased to 3.7% and the platelet count is 82,000. If you look at the scatter plot, this green area above the monocyte, as I told earlier, this is the area of the high fluorescence cells. So the principle is whenever after day 4, the HFC jumps from day to day more than 3 to 4 times, usually the platelet recovery happens within 48 to 72 hours from that point. So when you look at day 5, the HFC has already jumped 3 to 4%. From 3.5 it has jumped to 12.6%, and the platelet count has further reduced to 38. Now this is my point from which I have to look for recovery. Now I should get my recovery by day 7, day 8. I am knowing that 2 to 3 days in advance. This is the same patient day 6, day 5 scattergram. You can see that the HFC has increased here. Same patient day 6, platelet count is same plateau 43. But the HFC is now gone down 13.1%. Day 7, day 6 again scatter plot. Day 7, platelet count has recovered, HFC is further gone down to 4.9. So my base day was day 5, within 48 hours I have seen platelet recovery. So just similar to immature platelet fraction, HFC on its own is an important prognostic marker for the platelet recovery in dengue patients. Also, I have got now my own algorithm where if the HFC is more than 5%, platelet count is less than 50,000 and IPF is more than 20%, it is dengue even when you are serologically showing negative, because there is a lacuna in the serological test also. By day 5 and beyond, NS1 starts to become negative and antibody usually starts to become positive by day 7. So that 5 to 7 day window is one period where in those 2 days both NS1 as well as the antibody can be negative and they can trick you. So same patient day 7, you can see that the HFC scatter plot has reduced. Now last, coming to the platelet cell line. This is my most favorite cell line. It has given me most recognition. We have presented 3 papers on it. So first, coming to the platelet histogram. These are 2 variable discriminators, the lower and the upper discriminator. The lower one is anywhere between 2 to 6 femtoliters and the upper one is anywhere between 12 to 30 femtoliters, and we have this fixed discriminator at 12 femtoliter. So normal platelet histogram will begin at baseline from the lower discriminator and end before baseline at the upper discriminator. Next, the area to the right of the 12 femtoliter discriminator is the area of the platelet large cell ratio, and this broad base is the platelet distribution width. So if I see a histogram like this is a normal platelet histogram, I would not be worried about reporting a platelet count of 20,000 also. I might not even see the smear. This is good enough for me. But if I see these kind of histograms, then I would be very wary of reporting even 1 lakh. It could be tricky. So the methods of platelet estimation, I think for those of us who fought the dengue case against Mr. Kejriwal, we all know it by heart. So the most common method is the impedance method, which most of us are using. But unfortunately in dengue this doesn't work because there are both giant platelets, there are platelet clumps, there are fragmented RBCs, and because this is primarily dependent on cell size, this fails us in dengue. Next we have the optical or the fluorescent RBC, which is using on the RNA content of the platelets. And this is somehow a better method for patients of ITP stroke dengue where there is peripheral platelet destruction. Then we have something called as the switching algorithm, where the analyzer acts smartly, differentiates which one to use. For example, in a patient of cancer chemotherapy, if it is seeing too many WBC fragments, it will switch to the impedance mode. And in cases of ITP and dengue where there is more peripheral platelet destruction, high IPF, it will switch to the optical stroke fluorescent mode. So the analyzer can also intelligently decide for you which is a better methodology to use under which conditions. Next we have is the immunoplatelets, which are nothing but CD61 tagged platelets, which is the closest you can get to the gold standard, which is the fluorescent flow cytometry. But in an era where most B.WBC players are giving full body checkup at 499, if I sell platelet at 2000, both Kejriwal and Modi will be gunning down my lab to close it down. So next is flow cytometry, which is the international reference method, but because of again cost consideration, we can't use it for routine practice. This last method has held us good even when we didn't have all this technology, which is the manual method using both chamber and smear validation. And for some of us who are still on the basic hematology analyzer, this technology still works because it is dependent on the observer. So coming to optical stroke fluorescent platelets. So as you can see, there is this area of intersection of platelet and RBC where there are both large platelets as well as platelet clumps as well as fragmented RBCs and microcytic RBCs. So because of this reason, the impedance is problematic, but optical resolves this problem to a great extent, although with the caveat that not 100%. So once you do this scatter plot, on the y-axis is the forward scatter or the cell size, and on the x-axis is the fluorescence. This is the area of the optical platelet. This area which is towards the right, which is got both high fluorescence as well as high forward scatter, is the area of the immature platelet fraction. Mind you, this name is a misnomer. It is not just determining the reticulated platelets, it is also determining the giant platelets. So even in patients of congenital macrothrombocyte like the Harris platelet syndrome or the Mediterranean platelet syndrome, you will have higher IPF, although there will be no peripheral platelet destruction. So this is the workflow of the platelet that we use in our lab. We first use the impedance method. If the impedance count is more than 50,000, we report it as it is, and the scatter plot is histogram is normal. If the platelet count is less than 50 or the histogram is abnormal, we run the retic mode and we get the optical stroke fluorescent platelet and result using the switching algorithm. So immature platelet fraction was actually initially not designed for dengue prognosis. It was primarily designed in USA to differentiate without doing bone marrow hypoplasia vis-a-vis ITP. So in an ITP the IPF was very high, and whereas in a hypoplasia the IPF was lower than even normal range. So that was the primary indication, but even today it is used. It is one of the first indicators to look for bone marrow regeneration in a BM transplant patient. So as I said that it is depicting both higher fluorescence as well as more RNA. So these are the ISLS guidelines. If your platelet count is less than 1 lakh or more than 10 lakhs, if there are any flags coming out of your analyzers, especially if there is a platelet clump flag, you have to check the sample for clots, you have to do a slide review, and if clumps persist, then follow the lab SOPs. So briefly I will just share my 3 papers that I have done on dengue, predictive markers of dengue journey so far. This was the first paper that we presented in AIMS in 2015, peak immature platelet fraction as a predictive marker of platelet recovery in dengue patients. So our aim was to establish peak IPF in thrombocytopenic dengue patients and try to establish time to platelet recovery from the peak values. So these are the results. The peak IPF value ranged from 5.5 to 38.7 with mean of 13.5 and standard deviation of 6.4. One thing was very clear, we cannot set a ballpark figure to IPF. We have to follow it like a trend analysis. And 86% patients whose values were over 20% were ethnically from West Bengal, Bihar and Eastern UP, typically the Harris platelet syndrome belt. So I understood pretty early that there is an ethnic component to it as well. 100% patients showed significant platelet recovery after attaining peak IPA values and 86% within 72 hours. So it had a clear prognostic significance. So it was a promising predictor of time to recovery of platelet counts in dengue patients. And there was a previous study from Hinduja which said IPF of 10% can be used as a cutoff. So we kind of juxtapose that theory, saying that a single IPF more than 10% is not a reliable marker for platelet recovery. And peak IPF value in dengue patients of different ethnic groups can be a subject for further study, which it was. Dr. Sen Gupta presented a paper from Calcutta where she shows that the normal reference interval of IPF in West Bengal was very different than from most studies coming out of Delhi. We were all giving a biological reference interval of 5 to 6%, whereas she gave 14-15%. So this year, first time lucky, we got the first prize in that competition for this paper. Then this is our second paper. We tried to compare two analyzers, BC 6800 Mindre and Sysmex XN 1000, to look whether the IPF from the two analyzers correlated. So as you can see that the IPF value, R value overall was 0.960, and for less than 6 it was 0.972 and more than 6 it was 0.901. So it was showing good correlation between the two analyzers. I'll skip this. This is another prize that we got. This is the third paper that we presented at ISLH Vancouver 2019. Clinical evaluation of various predictive markers of platelet recovery in dengue patients. So here what we did was, instead of just focusing on IPF, we brought everything to the table. So we looked at mean platelet volume, we looked at IPF, we looked at high fluorescent IPFs, we looked at the high fluorescent cell HFCs that we discussed before. We also looked at neutrophil lymphocyte ratio, we looked at platelet lymphocyte ratio, and we looked at platelet HFC ratio. So we, instead of the whole lymphocyte, we did a ratio between the platelet and the high fluorescence lymphocytes. And apart from doing individual, we were also looking at jumps and falls. Jump was same 3 to 4 times over previous days, and the fall was when it fell more than 50% over the previous days. So just looking at the peaks and troughs, but also looking at the jumps and falls. So these are the delta values. I'll just come to the conclusion. So PHR trough and PHR fall were the best predictor of platelet recovery. What we did was, we did combine both platelets as well as HFC, and we did their ratios. They were the best predictor of platelet recovery amongst the parameters respectively. So platelet HFC ratio was the best parameter amongst all the parameters, IPF, HFC, PLR, NLR, NPV put together. So with these words, I'd like to thank you all, and we'll take questions in the end.